Hi, Joseph. Come in.
How are you doing?
I'm doing well. Come on over here. I know it's not very comfortable. You can sit down there if you want, otherwise.
Okay.
So we already went through your case, but I just want to go through the records that you have. Yeah.
I'll give you this too. Do you mind if I go through the plan? I know we went over it one time.
We can go through it. But I'll be happier if one thing is done before that, and that is a scan on my machine. So I can also do these little bit measurements, and I correlate the two, and so I know you're not anywhere different from what you were at this point in time.
Yes.
Okay.
I do know that because I had a scan from CT Systems. My occlusal plane angle is between 12 and 15 degrees.
Okay.
So, there is some room for counterclockwise rotation.
That's fair.
there. Yeah.
Okay, let's do that. So why don't we just quickly then take RCD,
Yeah.
so stuff gets in the system. I just go through it quickly,
fine,
then we
yeah.
go through this so we can crystallize things for sure.
Yeah.
Oh,
Yeah, that's perfect.
So basically, you understand what's happening, right?
Yeah.
So what we're doing is this kind of rotation.
Yeah.
You're okay with that?
Yeah. See, the problem with the counterclockwise rotation, a lot of times you lose vertical height.
Yes.
So what do you do?
I need to advance the maxillary.
Yeah, so we need
But you're giving just 2.5 millimeter advancement.
you can go 3 or 4 even.
I need to do more, yeah.
Yeah, that's fine, yeah.
Because
yeah.
otherwise you won't get the fullness here.
That's fine.
And you will get the height here.
Yeah, that's perfectly fine, yeah. In fact, I think when you smile, you should have 1 millimeter of gum.
Okay.
When you, I don't know if you agree with that.
Yeah. So this could go up, okay? So if you're going to stick with this, then this is going to go up.
Yeah, that's fine, perfectly fine. More is fine. You can go crazy as much as you want. Just, my upper midline incisor is coming forward 13, and then it's going down 2.9. But you could even go more, like you said. You can get more. That's fine. Yeah.
That's a lot.
So you're saying more than 2.9?
I'm saying 30 millimeters is a lot.
Oh, okay. No, 13 millimeters forward.
Yeah, that's a lot.
I think it's good. I like it.
Yeah, it's a lot though. I don't think we should do too much. I'm going to let me be honest to tell you, any movement more than 10 mm is a little difficult.
Yeah.
Okay. 10 mm is like the ballpark figure that we keep when we're doing osteotomy.
Yeah.
Because more than that is not only technically difficult, but also high relapse rates and warrants grafting.
Yeah.
Everywhere we can't be grafting because posteriorly grafting between the buttress and the pterygoid plate is not possible. Down grafting, possible.
Okay.
So this 12 mm, this 13, that should be the maximum.
Even if you gave me some bimax protrusion,
it's okay.
I'm fine with that. So
really?
Yeah, I think.
Okay.
I think this is my philosophy, and my philosophy goes against. I know they say that proportion. I know you said the 3 triad. You said symmetry.
Yeah.
Proportion and function. I actually disagree on the proportion part. I think facial disproportion, if done right, is what makes faces attractive. Look at Angelina Jolie. She has.
Oh yeah.
She has.
That's what we call as an anti-face.
Yeah.
Yeah. This anti-face is not a very old concept, and I think it looks pretty okay for some people to have a strong lower third of the face.
Yeah.
But if you have a very weak middle third, but then you shouldn't go for a strong lower third.
Yeah, because I also think.
So you're getting 13 millimeters of middle third advancement.
Yeah, because I have a severe sleep apnea. I have a sleep study for that. I can show it to you. It's not really relevant, but
it's relevant because it's going to get fixed with this.
Yeah,
It's relevant.
Yeah. I mean, I just want to open my airway also.
Absolutely. So the 12 millimeter down grafting increases your posterior airway a lot.
Yeah, I've seen there's a doctor. I forgot his name. He's in Switzerland. He
Herman Zeiler.
Zyler. Yeah, he does big counterclockwise rotations. He's famous for that.
He's my prof.
Oh, is he? Okay.
Yeah, I was with him.
So
he's in Zurich. He's a pretty old man now, though. Doesn't do a lot of surgeries. But yeah.
So my cuspid on my upper is coming in this plan is 10.6, and then down 7.9 with the counterclockwise rotation. So 10.6.
Okay.
and then down
7.9.
So then, see, what I'm proposing, I'm not,
What about the mandible exactly?
yeah, so the mandible, see, look, let me show you. See that when I do this? This is how I want it to look. It's
Okay.
extreme. I want this the most extreme advancement you could do.
Okay.
See how crazy?
Without wrecking your bite.
Yeah.
So what is the millimeter they say?
So this is 12.3.
Perfect. You remember this and this is related.
Yeah. See, yeah.
Because when you get to upper by 13, so over 12.
And then again, the upper midline incisor, or the lower midline incisor mandible in this plan is coming down 3.3.
Okay. So that's related to this.
Correct. Yeah,
So
correct.
that's okay. We don't have to worry about that. Next.
And the top molar,
That's
or
also
the,
okay.
excuse me, the bottom
No,
molar.
I want to go on to the genioplasty now.
Okay. Well, can I just go over? I know we just go over just for the heck of it. So the bottom molar is coming 13.4, and then down 6.6. That's related to the counterclockwise rotation.
And Pogonian 15.
16 actually, and down 7.9.
Okay, 1 second. That seems high again.
And then the genioplasty.
1 second. So Pogonian is 7, 6 and 18.
Pagonian 7.8.
Yeah, so that's 8, 6 and 8. That's half, roughly half.
Okay, yeah, so could you do the Pagonian, could you do 7.8 vertical?
So
yeah.
that 16 might be a little difficult.
Okay.
I'll let you know the final things. See, like I said, so the 12, 13 mm I'll do it.
Yeah.
This 12 I can do, but 15, 16, sometimes maybe it's 13, 12. Still will be
Okay,
good.
okay.
There will be significant change.
Yeah. I
Don't
mean,
have to worry about
if you
it.
go too big, I'm not gonna be upset.
Okay.
I'm not.
I get that
Yeah.
point. I get that.
Sorry. And then the
Yeah.
genioplasty, you might have to make some intraoperative decisions. Basically, the point of the genioplasty is one, increase for my stomion to my menton. I want to increase.
You want it plus 4.9?
Yeah, 5 millimeters for my stomion to my menton. Or no, sorry, anterior, posterior.
This way is 5.
Vertical.
4.
From stomion to menton, it says 4.2. But you could go 5. You can
Okay.
even go 5. And then it says minus 4.9. The minus 4.9, you might have to make an intraoperative decision. I just want my Pagonian to not be in front of my vermilion border.
Okay.
You know, I just, because
So
you don't want a Jay Leno chin, you know what I
Let me
mean?
get it straight. So what you're basically looking at with the chin, you want to get this height reduced and you want to increase the projection.
Well, more height, more height.
But anterior posterior is reduced. Okay, yeah. Anterior posterior.
Yeah.
See, that's not a good idea. Because if you reduce anterior posteriorly, you will get some loose skin there. Why do you want to reduce it?
Well, I'll let you make an intraoperative decision. I just don't want the Pagonian to be in front of the vermilion border. You know, like I just don't want it to be excessive, like a Jay Leno chin. You know what I mean? But I want really a lot of vertical. Like the Pagonian's coming down 8, so a lot of vertical. Like you see how my CT scan healed? I already gained 8 millimeters from this genioplasty. I want to gain another 4.5 or 5 from that existing position.
Especially in the vertical.
Yeah, see, this is an example. If you do something in 2 stages, like I think
I think what we'll have to do for the genioplasty, so I'll have to first remove the implants. And if you want 5 mm, I'll make a cut. I'll put the bone graft again inside.
Yeah.
So that way, because you're doing a revision, and then there's a lot of new bone that's formed, which is not as thick as the original bone.
Yeah.
So to get another 5 mm there without a graft is going to be difficult. And since I'm anyway harvesting the graft for the maxilla, so I might as well use another 5 mm ledge in between.
Okay.
So I get the height.
So you can give me another 5 here?
Yeah, I think that should be possible.
Okay.
But that should not be a difficult thing. But you want reduction in this 4 mm. Why?
Well, see,
4.9. Why don't we let that stay the way it is?
See, basically here in the plan, they have
I know, but 4 mm is very minimal.
Okay.
Remember, the soft tissue, when you take it back, tends to get loose. And
Okay.
It's like a balloon that's blown.
Yeah. Okay, I mean, if you want to just, take this to the operating room or.
No, I'm writing down my notes.
Yeah.
I'm going to do one more test for you. So that's an MRI dynamic sleep study.
Yeah.
Because you mentioned about your sleep study earlier. This will give me good information. I'll schedule this investigation for you either later today evening or tomorrow. And this is also going to give us a lot of information with regards to your airway.
Okay.
And not exactly in relation to your facial positioning airway. One other question on the same line is about your snoring.
Yes.
So how severe is it? Do you have it regularly? Don't have it? What is it?
It's like weird. Like normally I breathe fine out of my nose, but like when my consciousness falls below a certain level, I don't know if the muscles in my throat, if they loosen up, or if something with my smooth muscle happens. But then I get like. I get a lot of. I'm not sure if it's from the rhinoplasty. I had a rhinoplasty.
No. It's not rhinoplasty. It's because your posterior airway is less. When you open your mouth, there's more air that can go in. So all of this is indicative that I need to do this one test again. Why? Because 2 reasons. One for diagnostic reasons. Another one is also for therapeutic reasons post-surgery. So you could do a sleep dynamic 6 months later and you know like everything is the right position and you've sorted it out. Okay? So, dynamic sleep study के हमारे के दिन में नागर पुलिस स्कैन के दिन phone पढ़ने लोकल में वाइट दबी को है क्या
You can keep that.
Yeah, I'm going to keep this and
now did you get the other one? There's a before. There's some little side issue, like some side things. If you want to just like.
No, I want to mention about your cheek implants.
I have a scan I can show you if you want to see. I have an actual rendering of the cheek implants.
Okay.
You want me to show you? Yeah, I can. You want me to show?
But I'm going to. What if I have to remove the cheek implant?
Well,
I try not to.
Okay.
But there's a small chance I might have to.
I mean, if you absolutely have to, I mean, I don't want to sacrifice number one.
Yeah, that's an easy procedure. That's a daycare procedure.
Yeah, it's just, these were just, I mean, it has nothing to do with you, but I spent, these are custom implants, a lot of time and money went into them. But, I mean, I
can give them back to you if you can place them back, but then they don't do that in the US. It's not a good idea also. You want to get new ones made.
Because these are custom, like most doctors don't do custom, like these go like on the zygomatic arch, they sleep back. The off-the-shelf implants, they give men like that apple cheek, like feminine look. That's why men, it looks better if they get, the left side I think I got a good OD curve, the right side didn't turn out good. But, and I also got buccal fat pad removal.
Okay.
But I don't think they removed all of it. I don't know if you can check to see if they got all of it on the right side, if there's any buccal fat remaining. Because I have a fat face, as you can see.
That will be sorted out, don't worry. 100%. So I'm just
Do
going to
you
say...
like perioral liposuction or any kind of, no, okay.
I don't want to
Small
combine it with this.
Oh, yeah.
You can see, let me tell you very honestly, this is what they rendered. The result's probably going to be this way or even better.
Okay.
Because you're talking about major movements now.
Yeah.
13, 12, 15, 16.
Yeah,
I mean, your face is going to look very different, very nice. And therefore, I don't want to do something in CPC procedure along with that. Like this cannula, even a malar thing is itchy. It's a small thing for this procedure.
Yeah, okay.
So, maybe you wouldn't even need it.
Okay. I think I see a lot of people that are bimax protrusive. You know, it looks like they either got a facelift or they got submental lipectomy, but they didn't do any of that. They just got bimax and they look better.
Absolutely. Now, one thing I also want to discuss, which I haven't mentioned to you so far, is I would give you anesthesia through here.
Okay.
So we're going to do what is called as submandibular or transmylohyoid or submental, whatever type of anesthesia, because of your whole face to work with.
That's fine.
The biggest need for me is because I'm doing big movements, one, and secondly, also complex movements.
Yeah.
I have to tell you, I already mentioned this to you in my earlier conversation.
The 12 millimeter posterior downward movement is difficult.
Yes.
So
Yeah.
we definitely need augmentation. I also need the whole face. I can move around and keep the implant.
Yeah, if you could, like, if you could, I want more tooth show.
Sure, that will happen automatically.
So if you could go 3 or even 4 on the anterior nasal spine, you could go even 4 a little
Okay.
bit.
Yeah, I've already done that.
I mean,
So-
I don't really want. I'm not sure. Yeah, I want to follow the plan as closely as possible, but if you have to make an intraoperative decision, and you need to deviate from the plan, but I would like this kind of aesthetic.
Aesthetically.
Yeah, see, this is where I'm starting from.
Yeah.
I'm severely deficient.
Yes.
Yeah.
We'll get there. If not exactly a 90% or
Yeah.
10%, around this.
Okay.
So I will keep this
Okay, sure, yeah.
report with me. So we have to just run these blood tests, which is just customary basically. And what about RT-PCR and your vaccination?
Yeah, I do have a PCR vaccine. I got 2 doses.
So you would be able to give us a certification for that?
I have a copy of it.
Sure.
It's not a certificate, it's a card.
That's okay.
Yeah, up to Pfizer. It's
Anything.
Pfizer, yeah.
So you're gonna give us that RT-PCR? I will run your.
I give you a copy because I need to retain the card.
No, we just need a copy of it.
Yeah.
Just as Xerox. Take a.
I knew I would need that before I left the U.S.
Yeah, this is very important. The other thing which I haven't discussed is about the grafting. So we could graft either from the iliac crest or the rib. And when we're doing this kind of procedures, I prefer the iliac crest more. So if it's just like 12 mm here, 12 mm here, I might be able to manage with one iliac crest on the right side.
I would prefer if you actually took it from both.
Exactly,
Yeah.
I'm just getting to that. But if you take it on one side, the 2 issues, one side can, the crest looks a little bit in, you go to the
Yeah.
beach, and goes a little bit in, so it's probably better to take, 14 mm top, another 14 mm top,
Yeah.
take this thing down too, so I push it as a wedge here, and this one goes 1/2 here, 1/2
Yeah,
there.
I'm fine with that, yeah.
Yeah, so that's something I was thinking. So that means little difficulty in walking. Okay, we generally take from one side because you can limp and move around a little bit. So taking from the both sides, first couple of days maybe it's going to be a little bit hard for you to move around. But eventually it's not going to be that bad because we're taking less quantity per site
Right.
to get the symmetry and also to make sure that it's not over harvested and looks a little deformed in terms of the leg aesthetics. Okay.
But I just want my vertical, my face to just be.
I get it.
Yeah.
I get it. This is, and I can see the point. Okay.
I see you do a lot of class 3, and you do a lot of class 2.
No, I do a lot of
Yeah,
procedures
yeah.
like these
Yeah.
as well. So don't worry.
Okay.
This is, I think you're gonna be with us for 5 to 7 days, and maybe then you can move to the hotel and then still see us maybe once in 2 or 3 days
Okay.
for another week or 2. And by the time it's a month, it's gonna be fine.
Okay.
It's gonna
Okay.
be cool with everything.
Yeah.
All right. And is it okay if I remove your braces off, or you want me to have them back there?
Oh no, I need the braces to stay on.
Okay.
In fact, I don't know if it's possible. Well, there's different ways. Sometimes they do the hooks and the bands for
No,
stability.
I
but-
try to retain it, but what happens is when I'm using a lot of wires and pulling it down, it sometimes breaks. And then the orthodontist create problem. Even here, oh, you broke my braces, patient has to pay again and shit like this, and patient comes back to us and it's like, oh.
Yeah.
So I have to tell you beforehand.
Yeah. I mean,
It can happen. I
Yeah.
try not to. But I can't give you a guarantee saying your braces are not going to be disrupted.
Okay.
We're doing a lot of work.
Yeah, I mean, if you can try to, I mean, I would try to preserve the braces if it's at all possible. Is that possible, or what are my options?
The best is to take them off totally. That's what I like to do. Because otherwise, and I put a different kind of clips, these are not going to take my pressure. Remember when I'm doing these huge movements,
Yeah.
I need to move the jaw and fix it intermediate before I get the grafting and the plates. Those braces don't stay that. They don't withstand that kind of pressure. They break off. And when 2 or 3 break off, then the orthodontist is like, I don't do it again. So then it might as well be we remove everything. But if you don't want me to be removed, I will try to do it without removing it. Honestly, if you give me permission to remove it before we start, I'll be happy. I mean, it'll be nice now. It'll be easier for us when we make the splits. It'll be better when we plan things for you, when I put the split inside. Because I have to make wafers. Wafers are surgical splints that we make after we perform what's called as mock surgery.
Yeah.
So when the wafers are made, it's much easier for us to fabricate them when you don't have these braces. Also for taking impressions, and the dentists do them. So there are multiple reasons why sometimes braces can be a little bit of a hassle,
Yeah.
rather than beneficial. You would want to contact your orthodontist, or just
I really don't want to contact.
so we just do what it is, and if we think we can try and save.
I would just ask that if you try to preserve it, and then if something comes off, then it is what it is.
Okay, I'll go with that. Alright, so I'm going to do a few things with you right now. We're going to have them run the basic blood test, get you the slot for an MRI dynamic sleep study, and we're also going to be getting an upper lower impression, 2 sets,
And where's
photographs.
sorry? Where's the sleep study going to take place?
Not at the hospital, outside, at another center.
Could we skip that? Is that possible? or-
You don't want me to do that?
I don't. I don't want to do that
Okay.
personally. Yeah.
Why is that?
It's not my main. I
It's
know. I just want to I don't have the cab and getting there and.
We can
Just-
organize that for you from here. It's just another diagnostic test that gives more information to me, especially with regards to the positioning of the upper jaw, the posterior maxilla.
Okay. I mean,
If you're
yeah. I would
if you're
prefer.
not keen, I would
yeah.
skip it.
Okay.
But
I would prefer to forego it personally. But
Okay.
if you absolutely need it,
no,
I'll do it.
because you did mention about your sleep issues and snoring,
Yeah.
I'm thinking of getting that done to have that aspect covered in the
Yeah.
treatment plan.
Yeah, I just mentioned it. The reason I mentioned the sleep apnea is just to emphasize the amount of advancement.
Sure.
Just,
That's fine.
Just the advancement. That's the only
That's
thing.
fine. That
yeah.
we have measurements anyways.
Yeah, I
So-
would prefer to forego the sleep
Sure.
study. If it's
Okay, so
with you.
we get that off. We just get the bloods and we get the dentist to take the impressions and to
Okay.
make the splints and everything. And probably you're good to leave in about half an hour or something.
Okay.
And
I'm
then
glad that you pretty much agreed. I mean,
yeah, except a
almost
few
agreed
things
with my
on the
plan.
genioplasty and a little bit, only 2 millimeters maybe on some aspects, but otherwise by and large it's good. I already agreed, and that's why I said you can come over.
Yeah, I
I just said
appreciate
that I might
it.
need to put the graft in, which you agreed.
Yeah. You're saying with the down graft?
Yes.
The yeah.
Yes.
So you need that for stability, of course, right? Because if you don't, you're going to
Otherwise,
have a maxillary.
you can have a maxilla that doesn't fuse.
Yeah.
Spread members a lot. You
Yeah.
don't want some fibrous union happening there that causes problems for you in the future.
Correct.
So,
Yeah.
so that's something we have to do.
Right.
Okay, so இன்னைக்கு first நம்ம blood test எல்லாம் பண்ணி ECG எல்லாம் எடுத்து எல்லாம் இன்னைக்கு பண்ணிட்டு 2 cast எடுக்கணும், 2 cast sets and pour normal bite and try to preserve the braces. That's what I mentioned. Okay. And I'll do it a lot. Now I'm going to actually. All right. Thank you. Sharif.